Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. Today we're going to talk about pancreatic cancer. What is the pancreas? And why is it important to consider screening for this type of cancer? My guest today is Dr. Danielle DePeralta from the Surgical Oncology department at the Northwell Health Cancer Institute and an assistant professor of surgery at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Dr. DePeralta, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. Welcome.
Thank you so much, Jeanine. It's an honor to be here.
And it's good to talk about this topic. Tell me why you decided to focus your career on surgical oncology. What is your background?
So, I grew up on Long Island in Suffolk County. I went to Sachem High School, and no one in my family is in medicine. None of my family members are doctors or nurses or even remotely related to medicine.
Okay.
I went to undergrad and I loved studying science, so that the kind of natural progression sometimes as well. I think I'll go to medical school. So I went to medical school, and I thought actually that I wanted to be a pediatric oncologist. Because I loved taking care of kids and I loved the idea of helping, children and families through extremely difficult times.
Yes.
And felt like I could, have the compassion and kind of the resiliency to be there with them through this. And then when I was in medical school, surgery was my last rotation. And I started doing the rotations in the operating room, and I just fell in love with being in the operating room. There's something very satisfying and unique about the ability to take a concrete problem and fix it with your hands and see a patient through that kind of recovery. So then I decided I was going to be a surgeon. I was accepted into residency in Boston at Mass General Hospital, where I was for 7 years. And it was really during my time there that I realized that there's this unique opportunity within surgical oncology to kind of marry the relationship of a surgeon that fixes very tangible things, but also have the ability to treat patients with cancer and get to know them during, oftentimes one of the most trying and difficult times in their lives.
It is.
To have the opportunity to cure many of them, but also the patients that we can't cure, get to really share with them in this, in this very difficult experience.
So can we start off by just describing what is the pancreas? What does it do?
So that's a great question, and I'm glad you asked this. And I'll tell you basically what I tell all of my patients when I meet them, and I start off by explaining what the pancreas is. I often start off by saying it's an organ that's deep inside the belly, sits behind the stomach, and it's kind of shaped like a fish. It has a head, a neck, a body, and a tail. And then the analogy that I always use, especially because we live on Long Island, is the pancreas kind of looks like Long Island. And right through the pancreas is a long tube that runs right through the middle of the pancreas. And if you can imagine the Long Island Expressway going, from one end to the other, that's basically this long tube. And that's called the pancreatic duct. And the purpose of this duct is to help all of the enzymes that get created throughout the pancreas, which help you digest your food, drain into the intestines after they meet with the bile duct that drains the liver. So that's one of the functions of the pancreas, is to create enzymes that help you release your food. I also mentioned the duct because it's relevant, because that's where most of the cancers start. The other important functions of the pancreas are to make hormones, particularly the hormones that help you regulate your blood sugar, like insulin.
Tell me about pancreatic cancer. You talked about it usually occurs in the ductal area. Is that true?
It is.
Okay.
So most pancreatic cancers occur in the duct. The reason that's relevant is because sometimes when pancreatic cancers present, they can sometimes present because the duct gets blocked. Mm-hmm. If the duct blockage is very kind of early in the pancreas, towards the right side of the pancreas, or if you imagine towards like Brooklyn or Queens, then those patients can also develop jaundice because the bile duct, actually, that's where the bile duct meets the pancreas duct. And if the tumor blocks off the bile duct, which drains the liver, patients can turn yellow because their bile is not draining. Tumors that are further out, more distally, may not present with any symptoms at all of duct blockage. But sometimes the duct blockage can cause something called pancreatitis, which is inflammation of the pancreas. The analogy that I sometimes use is, if there's a traffic jam on the expressway, everything that's beyond that gets backed up. And that's kind of what happens when that duct gets blocked. The other thing that can happen is people can develop diabetes kind of out of nowhere, because one of the jobs of the pancreas is to help regulate your blood sugars. When it's not working well, patients can develop diabetes.
So how many people in the United States are affected by pancreatic cancer? And what is the mortality rate?
Yeah, it's thought that it's about 64,000 patients per year are diagnosed with pancreatic cancer. Wow. As many people may be aware, it's a very aggressive type of cancer. The 5-year survival rate only hit double digits within the last few years. It's right now around 11%. Wow. That's for all comers, though. So, how a patient will do really depends. It depends on a lot of things, but importantly, it depends on the stage of the cancer. So patients who present with stage 4 cancer that's spread to other parts of the body, most of the time those patients are not curable, and we do our best to treat them to keep them alive with the best quality of life that we can for as long as possible, knowing that we can't ever remove the cancer or get rid of it. Right. Patients with earlier stage cancers can do much better, and 5-year survival for very earlier stage cancers, depending on what you look at, can be higher than 30, 40, even 50%.
Wow. What are some of the predisposing factors for pancreatic cancer?
So, what I tell all of my patients is that most cancers are caused by some combination of genetics and environment and bad luck. And probably as we get more sophisticated with time, we're going to find out that a lot of that bad luck is really genetics and environment that we just haven't figured out yet. So if we tackle kind of the environmental things first, the major risk factors are really smoking, obesity. Those are really the things that are most convincing. When we talk about genetics, we know that about 5 to 10% of patients who are diagnosed with pancreatic cancer actually have a family member who'd already been diagnosed. So we've learned over time that there are some genetic predispositions towards developing cancer, which is an important thing, because when we know about that, then we potentially have the possibility of screening those patients and potentially diagnosing them earlier and giving them a higher chance of being cured.
So some of the environmental factors that predispose patients to pancreatic cancer, you mentioned smoking and obesity. Is there anything that is connected or tied to diet?
100%. When patients come to my office, that's a very common question. What should I eat? Should I cut out sugar completely? Should I, do sugar feed cancers? And the simple answer is we don't know, and it's very complicated. We know that a diet that's high in fats, that's low in protein, sometimes our traditional kind of American diets predispose people to develop obesity, and that goes in hand with development of diabetes, hypertension, high cholesterol, and all sorts of cancers, not just pancreatic cancer. So, if we're really going to tease out diet, what I tell people is, we want you to eat healthy. What exactly that means is a little bit different from person to person, but we want you to eat lean meats. We want you to eat fruits and vegetables. We want you to eat whole foods as much as possible to minimize things that are processed. But that also doesn't mean that you can't have, ice cream or a piece of cake on a special occasion. It just means you can't have that every day, multiple times a day.
So what would you say are the tests that detect pancreatic cancers?
So there are a few different tests that can detect it. The most of the time, patients that I see, the cancer has been detected on either a CAT scan or an MRI. And that's either obtained because someone developed symptoms, like they developed pain or they developed jaundice, and they went to their doctor who ordered an imaging study. Sometimes it's diagnosed incidentally. A patient's in a car accident and they undergo these imaging studies and we see a small mass in the pancreas. And then other times, these are also the same studies that we use for screening in the patients who may be at risk for pancreatic cancer. The only way to really 100% diagnose this is to be able to look at it under the microscope. In order to do that, patients either need a biopsy. That's typically done with a test called an EUS, or an endoscopic ultrasound, where a gastroenterology doctor goes down through the mouth into the stomach and puts an ultrasound or a sonogram probe on the back wall of the stomach and takes a little sample from the pancreas to look at it under the microscope. More and more, we're gaining interest in looking at blood samples to be able to detect cancers like pancreatic cancer. And this is an area of a lot of active study. There's nothing that's 100% yet, but I predict for the future that will be something that will be more relevant for, our kids' generation.
And what blood tests would one look at and notice in terms of someone that has pancreatic cancer? What levels would elevate?
So right now, there's some tests called tumor markers that we send, and these can be substances that are released into the bloodstream by the tumor. Not all patients make them, so they're imperfect, but the tumor markers that we follow are tumor markers called CA19-9 and CEA. Every patient who's diagnosed with pancreatic cancer, we check these tumor markers and we follow them over the course of treatment. These are not things that I typically recommend that the average person should be having checked, because there can be a lot of false elevations and it can create a lot of anxiety. And without findings on an imaging study, there's really nothing that we would do with that information.
Now, is this pancreatic cancer usually detected later in its stages, or typically is it diagnosed early? And why so, if it is detected later in its stage?
It's a really important question.
Yeah.
And unfortunately, pancreatic cancer is notorious for being diagnosed late. And the reason for that is because the pancreas sits deep, deep, deep within the abdominal cavity. So it's hidden away by a lot of the other organs. So there's not many symptoms that, occur. We talked a little bit about jaundice. That only happens if the tumor is in a very specific location. Other symptoms like diabetes, people may not be watching for, or it may not happen until late. The symptoms that we sometimes think about, like pain,
Right.
doesn't happen until the tumor gets to be quite large. So it's much different than other tumors like breast cancer or melanoma that are on the surface. You can feel it or you can see it.
Yeah.
Even colon cancer, people will usually develop some bleeding that could be an early sign. But for pancreas cancer, it's just kind of hidden away.
Yeah. So what is the mortality rate?
5-year survival for pancreatic cancer right now is 11%. Depending on stage, it can be much different. So if we're looking at patients with stage 4 disease, the 5-year survival approaches 0. We have very unique situations where patients are cured or alive beyond 5 years. For stage 1 and stage 2 cancers that haven't spread to lymph nodes, patients do much better. Those are the patients that we have an opportunity to potentially cure.
So we talk about transplantation for most organs. Is this possible for the pancreas?
Not for pancreatic cancer. So there is something called pancreatic transplantation. That's typically offered for patients who have, either chronic pancreatitis or they're getting a kidney transplant, and we're going to try to transplant the pancreas to help with diabetes control. But for pancreatic cancer, a transplant is not an option.
Why so? Why is that?
So if you think, most transplants that we do are not for cancers. They're usually, kidney transplants are done because patients have kidney failure and we're going to replace the function of the kidney. Liver transplants are typically done for patients whose livers are failing. We do transplant some patients with cancer, but it's actually a minority of the patients, and it's not just for the cancer typically. It's because they also have liver disease. For pancreas cancer, and for most cancers, we don't typically treat with transplantation. The other thing that's really key is when you give a patient a transplant, you have to give them immunosuppression. And we need the immune system to actually fight the cancers. Yeah. So when you immunosuppress someone after a transplant, the cancers may well come back very quickly and can spread to other parts of the body.
So what is the treatment for pancreatic cancer? How are we treating it? Still Whipple procedure or?
It is. So the surgical treatment Depends on the location of the cancer. So if you have a cancer that's in the head of the pancreas or towards Queens or Brooklyn, patients are treated with a surgical procedure called a Whipple procedure. If it's more out in the body or the tail, or more out in Suffolk, we treat those patients with something called the distal pancreatectomy, where we remove that portion of the pancreas. All patients with pancreas cancer, if they're strong enough to tolerate it, we also recommend chemotherapy. And it's really the best chance of being cured are for patients who receive a combination of both surgery to remove it and chemotherapy. We also sometimes incorporate radiation therapy for tumors that haven't spread outside the pancreas, but may be too large or in too tricky of a location to remove, or to help sterilize our margins after surgery. If we're worried that we could be leaving neighboring tumor cells behind, we'll oftentimes treat those patients with radiation.
So you described the pancreas and its function. What happens once that pancreas is removed? How are we replacing, I know, the beta cells and the digestive enzymes? What are we doing for that post-surgery?
Yeah, it's a really important point. So after surgery, patients are usually in the hospital on average about a week, sometimes a little bit sooner, but if they have any complications, it can be longer. While they're in the hospital, we're frequently checking their blood sugars. Some patients are diabetic at baseline and may take insulin before surgery. Those patients will all, for the most part, need insulin after surgery. If a person doesn't have diabetes before surgery, most of the time they don't develop it after surgery, but there is that risk. So we follow very closely, just like we would with anyone else that we're watching for diabetes. And if it develops, then we treat it with the same medications that we would treat for other patients who develop diabetes. Okay. The other thing that's really important and so critical for our patients with pancreatic cancer is nutrition, being able to keep their weights up. And this is why, we talked earlier a little bit about diet. I'm always very reluctant to tell patients to focus too much on a healthy diet, right, because patients lose a lot of weight with pancreatic cancer. And the average weight loss after a Whipple can be up to 15 to 20 pounds. So I oftentimes just tell people I need them to eat anything, whatever they will eat, even if it's ice cream. Like I need them to get fat. I need them to get calories. I need them to
They don't have an intolerance for anything after the Whipple? Or they can...
So the most common thing is people feel full early. Yeah. So, I tell people you need to eat 6 small meals a day, not necessarily 3 full meals. And all day I want you walking around with protein shakes or little snacks just to keep getting nutrition in as much as you can. The other thing that we oftentimes have to add are enzymes to help replace some of the exocrine function of the pancreas. You sometimes hear the commercials on the radio for exocrine pancreatic insufficiency, or EPI, that can develop after surgery to remove the pancreas. So sometimes we need to give patients those enzymes back to help make sure that they're absorbing the food that they're taking in.
So are there any clinical trials available for patients?
Yeah, there are. And the landscape of clinical trials is constantly changing. One of the benefits of being seen at a big location like Northwell or other, major cancer centers is we're constantly evolving our clinical trial portfolio. Right now we have several trials open, and our goal is always to have a different trial open for every stage of cancer to make sure that patients are getting the best possible, most cutting-edge care. The other things that clinical trials do is it really helps to standardize care, because everything has to be very specific, so we can make sure that patients are getting the right treatments at the right time, and we're tracking everything.
You're listening to Your Family's Health on the Voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today you're learning about pancreatic cancer. My guest today is Dr. Danielle DePeralta from the Surgical Oncology Department at the Northwell Health Cancer Institute and an assistant professor of surgery at the Donald and Barbara Zucker School of Medicine at Hofstra. We talked about some research. So why is this so critical that we really talk about this and talk about the collaboration that you have with Cold Spring Harbor Laboratory?
Oh, for all cancers, this is certainly not unique to pancreatic cancer, but for all for all cancers, research is really critical. that's how we learn from each other. And this is how we help, do better for the next generation and for the patients who will come after, the ones that we're treating now. This is how we learn about the disease, and this is how we're going to develop the treatments that are going to become the standard of care for the future. We've come a long way with pancreatic cancer, but we still really have a long way to go. Here at Northwell, we have a very unique collaboration with Cold Spring Harbor Laboratory. There's a scientist, Dr. David Tuvison, who runs, a very robust translational laboratory that studies pancreatic cancer there. And we've been very privileged to collaborate with them. And we share a lot of, every time I take a patient to the operating room for pancreatic cancer, we give them the option to have some of their tissue sent to Cold Spring Harbor, where they can use that to develop organoids, which are little testing specimens to help us identify what are the best treatments for pancreatic cancer and to help learn from it for the future. So we try to, we collaborate with Cold Spring Harbor as much as we possibly can.
So after surgery of your patients, after the removal of the pancreas, what is the survival rate generally?
So what we've typically said is that, 20% of patients are candidates for surgery who are diagnosed with pancreatic cancer. So that means the other 80% have cancers that are either spread outside of the pancreas or who locally are too involved with the major blood vessels that it would be unsafe to remove them. And then we say of those 20% that make it to the operating room, about 20% of those are alive 5 years later.
Wow.
That is actually improving. So I used to say those same statistics 10 years ago when I was studying to do this. There are some encouraging clinical trials, and of course, clinical trials is not necessarily reflective of the real world because it selects for the strongest, fittest patients who kind of make it through all of the therapy. Mm-hmm. But in some trials, 5-year survival can be, upwards of 40 or 50% for patients who have the tumors removed completely. And again, it really depends on stage. That gets us back to kind of this idea of screening. Our entire goal with screening is to diagnose cancers as early as we possibly can to give patients the best chance of being cured.
You mentioned that pancreatic cancer, the beginning of this segment, you mentioned that pancreatic cancer is on the rise. Do you have any reason or rationale why that is? Why the rise in pancreatic cancer?
It's a good question. A lot of cancers that we're seeing more frequently in younger patients, and that is absolutely the case with pancreatic cancer. Later this month, I'm planning to do a Whipple surgery on 2 patients who are in their 40s, wow. Which is very young. We know that our lifestyles, despite, potentially people's best efforts, our lifestyles are not the healthiest. We don't eat as well as we probably should, and we don't, we're not as active as perhaps we could be. Mm-hmm. And I think that plays into it. There are also a lot of other cancers where we've made more progress than we have with pancreatic cancer. So, even though breast cancer, lung cancer, colon cancer are much more common than pancreatic cancer, we've made a lot more strides in those. Mm-hmm. So we may actually, see survival rates consistently improve for those cancers. Whereas for pancreatic cancer, even a 1 or 2% increase in 5-year survival rates, we take that as a win. So there's just a long way to go.
So do you treat patients across the lifespan? Do you ever see any very young children having pancreatic cancer? And how does that compare to the older adult?
So extraordinarily uncommon in young children, mm-hmm. thankfully. I've seen a handful of cases in my career. And usually the tumor biology is a little bit different than what we typically see in adults. So it can happen, but it's extremely, extremely rare. When it does happen, sadly, it's often very aggressive.
So you're really treating people who are in their sixth decade of life or more beyond that?
More. The most common ages, men are typically diagnosed a little bit younger for whatever reason. There's also a slight male predominance of pancreatic cancer, but most patients are diagnosed in their 60s and 70s.
Is there such thing as pancreatic cancer after the chemotherapy, after the radiation, that person is now free of cancer? Or what is the return? What is the likelihood of it coming back after even the most aggressive treatment after the surgery?
Absolutely. So there absolutely are patients who get back to normal life. And that's, to be honest with you, that's one of the most rewarding parts of my job is, we'll do surgery on someone, and then they'll typically do 6 months of chemotherapy after their surgery. And then I get to come back and see them once they finished chemo, and they're just, they're weak and they're deconditioned and they're just kind of getting ready to get back into the world. And then I still follow them when they get scans every 3 to 4 months. But once they're 2 years out, 3 years out, they're back to work, they're back to traveling, they're back to living their normal lives. So that's that's by far the most rewarding part of my job.
So I'm going to ask you a very cosmetic question about pancreatic surgery. How large is that incision? And where is the incision in terms of how do you access that pancreas?
Yeah, so there are a lot of different ways to do this. I think the most common way is an incision straight up and down. So, the most common thing is an incision right below the breastbone that goes just right around to the belly button.
Okay.
Some people that I trained with or I know from other places will do more of what's called a right subcostal incision. So an incision that goes, kind of diagonal along the right side underneath the rib cage. More and more, there's interest in doing surgery minimally invasively. So, there's something called a robot.
Right.
That pancreas surgery has been slow to be adapted for that, particularly for the Whipple operation. For distal pancreatectomies, we do that all the time. But more and more people are gaining experience with doing it robotically. So I think in the future, we'll see even more and more pancreas surgeries being done minimally invasively. Now, that being said, the recovery from pancreas surgery is not from the incision. It's from everything that's done on the inside. So we have to balance making sure patients get a perfect cancer operation with trying to just do small incisions.
So where can someone find out more information about you and the work that you do?
So about me, you can Google me. You can look at my, my Northwell website, and I'll share, my phone number from my office, 516-941-1251. And, people should feel free to reach out.
So this was very, very informative. And thank you for being here, Dr. Danielle DePeralta from the Surgical Oncology Department at Northwell Health Cancer Institute and an assistant professor of surgery at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. We thank you for giving us all this important information today, and good luck with you in all the work that you're doing at Northwell.
Thank you so much, Jeanine. I wish you and the listeners all the best. Thanks very much.
Awesome. This is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. And we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the nursing department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.